Hola, me llamo Milan Jr. y soy el vicepresidente y director de defensa de AIDS United. Bienvenido a AIDSWatch. Estamos muy contentos de que se haya unido a nosotros hoy. Hi, my name is Milan Jr. and I'm the Vice President and Chief Advocacy Officer here at AIDS United. Welcome to AIDSWatch. We are so glad to have you join us today. Escuche atentamente a la información sobre los servicios de traducción. Seleccione su idioma usando el botón de interpretación en forma de globo terráqueo. Si usted está usando su computadora, el botón de interpretación se encuentra ubicado en la parte inferior derecha de su pantalla. Si usted no desea escuchar la narración en inglés de fondo una vez que haya seleccionado su idioma, vaya a la opción Menú y seleccione Silenciar audio original. Si usted está usando un dispositivo móvil, Android o Apple, haga clic en los tres puntos ubicados en los controles de la reunión y seleccione Interpretación del idioma, luego seleccione Español. Si usted no desea escuchar la narración en inglés de fondo, seleccione Silenciar el audio. Gracias. Comenzaremos la presentación en breve. Thank you. We will begin the presentation shortly.
Good afternoon. Welcome and thank you for joining this special urgent edition of AIDSWatch, where we're addressing the growing monkeypox crisis for the HIV community. I'm Jesse Milan, President and CEO at AIDS United, and it's my pleasure to co-moderate this, our 5th virtual AIDSWatch and the 3rd ever in the fall. Joining me today as co-moderator is Chauncey McGlathery. Chauncey?
Hello, my name is Chauncey McGlathery. I am the Policy and Advocacy Manager for Thrive SS and the Sexual Justice Coordinator for the Zero Project.
Thanks, Chauncey. First, I'd like to thank our planning partners for AIDSWatch, the U.S. People Living with HIV Caucus, the Center for Health Law and Policy, as well as the expert panelists who are joining us throughout this seminar. And most of all, thanks to all of you advocates for continuing to create a virtual spirit of unity at AIDSWatch and a spirit of hope as well. And mostly, thank you for bringing your spirit of resilience and power to this important effort. Chauncey.
This year, the monkeypox outbreak and our fumbled response thereto have burdened our HIV community disproportionately and unnecessarily. We are currently living through not 2, but 3 pandemics, 4 if you count racism. These are threatening the well-being of millions of us, particularly in communities of color. Additionally, we face endless attacks on our reproductive justice and threats to accessing the care we not only need, but deserve, such as with the overturning of Roe v. Wade and the recent Texas PrEP ruling. All of this as we prepare for a critical season of midterm elections amid a desperate need for community-led healthcare reform. Too often, when our community suggests reforms, advocates in this space are battered by scientific jargon, wielding biomedical frameworks and terms of art that cloud the original point and the greater good. This defensive and adversarial posture threatens health equity for all of us, especially those who look like me, those who have been marginalized, and those who have good reasons to distrust the establishment. Hopefully today, we will be able to keep the conversation fresh and relevant as our very lives are at stake. Hopefully, we will also hear about new MIPA initiatives, community-based partnerships, and other effective feedback loops that allow advocates, networks, and community members to respond to bad policy, not only after it has failed to address our concerns, but even before those policies and procedures are established, given that so many of us exist in a viral underclass created by big business and tone-deaf policy making. After all, we're not just talking about diseases, pandemics, and pre-existing conditions of various kinds. We're talking about public health. With our population of people living with HIV living longer and growing older, we need advocates who are ready to take on the challenges of not only ending the HIV epidemic, but also advancing the care and holistic well-being of those living with HIV, not only at the federal level, but the state and local levels as well.
I so agree, Chauncey, and that's why AIDSWatch is so important. Together, we can speak truth to power to create political will necessary for all of us to end this epidemic. And it will take every one of us doing our part, lawmakers, policy experts, and everyday advocates and voters as well. Today, we're gathering for the first steps in this process to learn about the ongoing monkeypox policy discussions that are happening at our federal level, and for policymakers to hear from us about what some of our community concerns are regarding the monkeypox response. We're joined today by political analysts, by journalists, by policymakers, and by clinicians who are not only experts in the HIV response, but they are people living with, impacted by, and vulnerable to HIV themselves. We will also hold time for all of you to participate by asking questions. So please put your questions in the Q&A. That segment will be one segment for all the panelists together at the end of this session. So please utilize the Zoom Q&A to submit your response. But please avoid using the chat for questions, so that the Q&A questions can be reviewed and voiced during the session or for later response. Chauncey?
Without any further ado, we'll jump into the heart of it and hear an update on the most pressing policy issues related to the nation's monkeypox response and how these impact people living with HIV. Please join me in welcoming Rachel Deitch, Policy Director at the National Coalition of STD Directors, Bashar Jenkins, Policy Manager at AIDS United, and Dr. Sean Cahill of Fenway Health.
Thanks, Chauncey. I'm going to go ahead and get us started. Hi, everyone. My name is Rachel Deitch, she, her pronouns, and I'm the Director of Federal Policy at the National Coalition of STD Directors. So NCSD has been working since the first days of the outbreak to bring about policy solutions that'll aid in the response. NCSD Clinic Plus survey results that we've put a survey in the field multiple times to see what's going on and what folks are facing. And we learned very quickly that about 60% of MPV cases and MPV patients also had an STI. And this has been affirmed in last week's MMWR from the CDC, wherein they found that 61% of MPV patients had an STI in the last year and or were living with HIV. And we also learned very early on that the situation for sexual health clinics on the ground is dire. They've been absolutely slammed. I think folks on this call are probably well aware of that. Clinics are seeing double their usual number of patients with a whole new set of concerns in some areas. And just last week, I heard from a clinic in Indiana that they're spending $80,000 a month on MPV. They aren't the only one in that position and they need help. So it was also pretty clear from day one that we couldn't, and nor we shouldn't try to do this alone. And in June, NCSD formed the National MPV Working Group, which I currently chair. Today, working group members represent more than 50 national, state, and community-based organizations working in public health and LGBTQ rights. We focus our advocacy in two areas. First, funding for those on the front lines. And second, to reduce administrative burdens to providing care for MPV, including testing, treatment, and vaccine administration. We also use the group very informally as an information sharing and gathering space. This outbreak is changing rapidly, and we rely very heavily on each other for the latest news and developments, what's working, what's not, where are there communication breakdowns, and who has resources to share with the group. I'll skip over what we did early in the outbreak and focus on our latest actions that are pertinent to the conversation today. So right now, as many of you have probably heard, Congress is working on a CR, a continuing resolution. Essentially, that's required to fund the government. And it's important to our conversation today because it's also an opportunity for the White House to request new funding that they perhaps didn't anticipate needing for 2022, such as a new infectious disease outbreak in the United States. And this matters because a few weeks ago, the White House submitted their supplemental funding request to Congress, which included a request for $4.5 billion to respond to the critical needs MPV presents. This request is incredibly comprehensive. Around $3.9 billion of that funding would be for domestic HHS activities to support Ryan White clinics, community health centers, STI clinics, states, localities, everyone working in a comprehensive manner to mitigate the harm of this outbreak. It also supports research and vaccine and treatment procurement. So this will go a long way, right, to giving folks on the ground the resources they need to end this outbreak, including the space to really tackle these endemically. When someone needs to be tested for MPV, of course, they're already also being tested for STIs, but there's also a ton of other opportunities to educate on PrEP, for example, at vaccine clinics, and do so much more. So how did the working group engage on this? Very quickly. We, earlier this week, sent a letter, I believe on Monday, to Congress, specifically appropriations leadership for the wonky folks here, in strong support of the White House ask, which I believe someone will be throwing in the chat. The letter has been circulated far and wide and is being used daily in our advocacy for folks working on the ground. And it's just one example of the advocacy we engage in. We're meeting every other week to talk about how we can move the needle and what other levers we can pull to raise the alarm on this outbreak. And if you are with a national, state, or community-based organization that engages in federal advocacy, please consider this my invitation to join the working group, get involved. Folks can start by sending me an email or getting in touch with me just to learn more, or just dive right in and join. And I want to speak really briefly beyond joining the coalition. There was a hearing on monkeypox in the Senate yesterday that I'm sure many folks are aware of, and it showed simultaneously how hard people are working in the field, how hard CDC and HHS is working on this, and how many senators are unwilling right now to do what's necessary to end this outbreak. AIDS United and NCSD are members of the Partnership to End HIV, STDs, and Hepatitis, and we submitted a letter for the record, thanks to Senator Smith, calling attention to the need for a syndemic approach. We called attention to the need for vastly increased efforts to achieve racial and ethnic equity in vaccine testing and treatment and administration, as well as honest, accurate, culturally competent communications to make sure everyone has the information they need to make empowered choices about their health. But our advocacy as national organizations can only go so far. They really need to hear from you, constituents working, living, breathing, experiencing this outbreak in their districts and states. So Bashar is going to talk a little bit more about that and how you can get plugged in. But first, I'd like to turn it over to Sean to talk about some latest report out of Fenway.
Great. Thank you very much. So earlier this week, we at the Fenway Institute at Fenway Community Health Center in Boston released a policy brief titled "How the Federal Government Can Better Respond to the Monkeypox Outbreak." I'll put a link into the chat so you can access the policy brief probably right after I finish speaking. But here I'll give you a few highlights. The most frustrating thing about the last few months has been that, unlike with the HIV and COVID-19 pandemics, when the first individual was diagnosed with monkeypox in Boston, May 17th, we had vaccines, tests, and treatment available. And had these been deployed effectively, we as a society could have stopped monkeypox in its tracks the way we did in 2003 when we last had an outbreak. But instead, we now have about 22,000 people diagnosed with monkeypox in the US. We're about 40% of the global cases, more than any other country in the world. These individuals are overwhelmingly gay and bisexual men, and they're disproportionately Black and Latino. And as was highlighted in the Senate hearing yesterday, the federal government, and in particular the Administration for Strategic Preparedness and Response and the Food and Drug Administration, really mismanaged vaccine supply and distribution. And this enabled the virus to spread rapidly and to reinforce pre-existing racial, ethnic, and geographic inequities in healthcare access. Black and Latino gay and bisexual men and other MSM are disproportionately getting diagnosed with monkeypox compared to other gay and bisexual men, but they are less likely to be vaccinated. And there are also geographic and class disparities. So for example, as of late July, Baltimore got its first batch of 200 vaccines, but at that point in time, the District of Columbia had received 14,000 doses. We have concerns about the shift to intradermal administration of vaccines, which occurred a little over a month ago. And we are especially concerned as it relates to people living with HIV. And I'll talk a little bit more about that when I give some recommendations. The Washington Post characterized this shift from a subcutaneous vaccination approach to intradermal administration as, quote, a large-scale real-time experiment. Monkeypox testing was rationed in the early months of the outbreak. It was hard to get a test. Individuals had to do a huge amount of self-advocacy, and people were refused tests. For example, one person was refused to test in Baltimore because he only had one lesion, and he was told they were holding tests for people with 2 or more lesions. They were also misdiagnosed. So the same individual was told, that's not a lesion, that's an ingrown hair, when it was in fact a lesion, and he eventually got more lesions. We have almost 2 million doses of TPOXX treatment available to treat people with monkeypox. This can help reduce painful lesions really fast, often within a day or so. But unfortunately, many providers and patients don't know that treatment is available. And if they do know that, often bureaucratic obstacles can make it hard to access treatment. Until late July, providers, healthcare providers, doctors, and other providers had to complete about 5 hours of paperwork per patient to enroll them in a clinical trial that was required to access TPOXX. The Centers for Disease Control simplified this in late July, but it can still be hard to access treatment, especially in poorly resourced health facilities. And this contributes to those disparities I mentioned earlier. So what are the solutions? I'm just going to mention a few. There's more in the report that I'll put into the chat. One would be an emergency use authorization for testing. This would help lower the regulatory burden and help mobilize academia and diagnostic companies to develop new modalities of testing, such as home testing. We'd also like to see testing made free for all. We'd also like to see an emergency use authorization for vaccination, and also strongly encourage the Biden-Harris administration to invoke the Defense Production Act to scale up production of vaccine immediately. Please try to get the 15 million doses that we own, the US government owns 15 million doses of vaccine from the manufacturer in Denmark, Bavarian Nordic, but we want to get them here to the US and put them into vials in the next few weeks so that we have sufficient supply to vaccinate the 1.5 million gay and bisexual men who are at risk and possibly other populations who are vulnerable to infection. We'd also like to see an emergency use authorization for treatment, which could reduce barriers to access TPOXX. We encourage President Biden to lead a global effort with the World Health Organization and allies to scale up vaccine production globally and to really try to eliminate monkeypox in Central and Western Africa, where people have been suffering and dying for 52 years. And at a minimum, get the vaccine to people, get treatment to people so they're not suffering in pain and not dying at such a high rate. HHS should also closely monitor the intradermal vaccination approach, especially with people living with HIV. Dr. Michael Osterholm from the University of Minnesota told the Washington Post about a month ago, when we shifted to this new vaccine approach of intradermal vaccination with about 1/5 of a dose from a vial, he said, we don't yet have the data to know how effectively an intradermal administered vaccination will protect immunocompromised persons. We'd also like to see more research, and we need funding for that research. We'd like to see research on PEP and PrEP with TPOXX in civilian populations. There's currently a Department of Defense study underway, but it should be broadened to other populations. And the last thing I'll say is we just need funding. As Rachel mentioned, President Biden made this $4.5 billion request for monkeypox response. And my understanding is that Republicans in the Senate are blocking this. And they're saying that they're doing that because it will exacerbate inflation. For 4 months now, federal agencies have been creatively moving funding around, but health centers and other organizations that have been providing a lot of the extra care with no federal support and minimal state support. So we really call on Congress to address this public health emergency now with funding, including funding for research so that we can better contain monkeypox and eliminate it here and around the world. And I can mention a few positive things that the government has done. I know I've been pretty critical, but a lot of good things have happened too. And maybe in the discussion, we can discuss those. Thank you.
Good afternoon, everyone. I'm just going to add a little bit of context in addition to what Dr. Cahill and Rachel mentioned, but briefly discuss some of the midterm elections, the midterm election and their potential impact on the monkeypox response. Clearly, we cannot understate how important the November midterm elections are for the future course of controlling the monkeypox epidemic. As recently as last Wednesday, the Senate Minority Whip expressed that Senate Republicans have, and I quote, zero interest in investing additional funding for COVID or monkeypox in a government funding bill to fund the government past September the 30th. As it currently stands, there seems to be an appetite for using and repurposing COVID funding and repurposing it for monkeypox instead of providing specific and substantial monkeypox funding to address the monkeypox epidemic. This approach is clearly untenable. Both of these public health crises, monkeypox and COVID, deserve substantial investments to end their impact on the country. We are currently about 8 weeks away from the midterm elections, and it appears that this midterm will be quite close. which is unusual since traditionally the party that controls the White House loses seats in the midterm elections, but it's not clear that this year's election will follow that traditional path. Clearly, if Republicans gain control of the Senate, it could potentially jeopardize any efforts to meaningfully address the monkeypox epidemic, as Senate Republicans have expressed little to no appetite for additional funding for monkeypox. However, if Democrats are able to narrowly maintain the House and potentially expand their majority in the Senate, this would not only give us a clearer path toward investing in monkeypox vaccine development and distribution, but it would also give us a clearer path for creating the infrastructure that we need to prevent future epidemics and pandemics. So AIDS United has developed an action alert, which can be found in the chat, for advocates to tell Congress that we cannot afford to have pandemic fatigue when it comes to our public policy response to monkeypox. This alert calls for Congress to appropriate $4.5 billion in emergency monkeypox epidemic funding for vaccine development and distribution, for expanded monkeypox testing and treatment efforts, to ensure that we have culturally competent public education campaigns that are directed at healthcare providers, the public, and the communities that are most impacted by monkeypox, as well as ensuring that there's an increased resource allocation and outreach to Black and Brown men who have sex with men who are disproportionately impacted by the monkeypox epidemic and have had a very difficult time accessing vaccines, accessing testing, and of course, receiving the TPOXX treatment as well. So we ask that you would disseminate this action alert widely with your networks to ensure that we have a robust public policy response to addressing the monkeypox epidemic. Thank you.
Thank you so much to all of our amazing panelists. I'd like to offer my gratitude not only for the fabulous job that they have done here today, but also the work that they do every day. Thank you, Rachel. Thank you, Sean, and thank you, Bashar. And I am definitely looking forward to reading that report from Fenway Health. I'd also like to celebrate the formation of the National NPV Working Group with this acknowledgement that advocates in the community must always be a part of the process, and the sooner the better. I also want to celebrate the increased efforts to achieve racial and ethnic equity in vaccine distribution, testing, and treatment administration, and also the honest, accurate, culturally competent communication. Policies that are contrived in ivory towers and marbled office buildings always come with unexpected challenges. It is one thing to create policy, it is quite another to grapple with its meaning, interpretation, and practice in the community on a daily basis. I have seen firsthand how challenging it is to deal with policies that have not been vetted by community. This impossible work that our culturally competent and culturally humble community practitioners endeavor to accomplish in our clinics is invaluable. US people living with HIV caucus and advocates across the country are grateful to partner with and witness the work they do, even after hours, to bridge the gap and make sure that the people who need these interventions most are not left out in the cold. And so next up, we are pleased to welcome practitioners from 3 different geographical areas in the United States. These community clinicians include Dr. Ford from Washington, DC, Dr. Shrikanth from Houston, Texas, Dr. Folks from Atlanta, Georgia, and joining them with a bird's eye reporter's view and personal experiences with similar community providers, we have Juan Michael Porter II.
How shall we start this conversation, chaps?
I have Dr. Ford first, is that correct?
Yeah, I can definitely go. So I'm Dr. Tyrus Ford, nurse practitioner here in Washington, DC, and I also practice in Maryland as well. I right now, I currently work at a non-for-profit, Black gay-led non-for-profit in Washington, D.C. And then interestingly enough, I work at another organization in DuPont Circle, which has a entirely different demographic. So I get to experience, my perspective is a little bit unique in that I get to experience two sides of the coin. One area where we experience a lot of barriers with one group of individuals, particularly gay and Black and gay, bisexual and transgender individuals. And there's the other side of the coin where I see a lot of white individuals who have, been coming to the clinic quite often to get screened for monkeypox. So it's quite interesting to see how each clinic works. So I'm definitely excited to answer some more questions about this perspective, but in my experience, I've definitely been seeing some barriers in terms of access to the vaccines, and then also being screened at the Black gay-led non-for-profit that I work for. It was extremely difficult to even to guide patients to the healthcare departments. They were telling them to come back to their primary care providers, which definitely was difficult to deal with. As a provider, you didn't know what to do and how to give these individuals treatment. And then there's the other side of the coin where I was at DuPont Circle, and we had treatments on site. We had the access to actually screen individuals for STIs and monkeypox. And they could have walked out with treatment. Yeah, we had to do paperwork. The paperwork was it wasn't as intense as as monkeypox first rolled out, but it was very interesting just to see those two dynamics. So I'm in a interesting spot right now as a clinician and still trying to navigate how to advocate best for individuals who are not able to get the best treatment with monkeypox, and preventing individuals from getting monkeypox, especially our marginalized groups. So yeah.
Thank you for that, Tyrus Ford. I guess I can go next. I am Dr. Folks. I am Jamaican, but I reside in Atlanta, Georgia. I work with a 501c3 organization called Thrive SS, and we work primarily with communities of color, particularly Black, the Black demographic. We work with generally Black queer men, but we also have extended or reach to persons of other communities, to persons of the transgender community, cisgender women, etc. And we provide services to multiple persons across the community. That being said, when monkeypox first hit Atlanta, it was very interesting to see the distribution of the diagnoses. Initially, we saw where multiple persons were being diagnosed with monkeypox, and we saw where they weren't necessarily sure what it was, and there were some who were not necessarily reporting it out of fear, out of concern. There were certainly vanity issues involved, and of course there were persons from marginalized communities, the ballroom community included, who had very unique experiences with monkeypox. There were persons who were voicing that this was not looking like the images that were being circulated on the internet. We've seen these very florid, very severe looking cases that have been on display, yet there were very mild looking cases. We didn't see as many lesions. And of course, there was concern, how do we differentiate these things? So at Thrive SS, our main approach was to step in and attempt to educate the community on how monkeypox could present, what were some of the things that, persons were experiencing. But as we went along, we had to learn as well. This wasn't something that we knew all the steps, we knew all the answers. This was something where we had to do the research and really listen to the community. So that was the benefit of working with a community-based organization. We learned of the atypical presentation that was happening, and we were also made privy to the prevalence among within the community of persons living with HIV. And that was particularly alarming because we've seen, based on data that we have collected, that persons, were maybe about 50% of the persons that were diagnosed with monkeypox were living with HIV. Thankfully, the majority of whom were virally suppressed, but of course that raised concerns for the parts of the community who did not know their serostatus. There were persons who may have not been virally suppressed, and of course, being able to address the issues of what did care look like for persons who were not virally suppressed, how could they inform themselves and protect themselves. So our strategy was mainly to attempt to educate as much as possible. But then, of course, when it came to access, this was where things became very interesting, because once the vaccine rollout started, this was a situation where there were clear differences based on socioeconomic status. I can cite, for example, persons who are from the African-American community who do belong to scenes such as the circuit scene, for example. They were in the know, even though they were a minority in those scenes. They were in the know and they were able to access vaccinations very quickly because the knowledge circulated very rapidly within those scenes. And we saw where initially Caucasian persons were the majority of the persons who were receiving the vaccine within the first 1 or 2 weeks. There were a lot of advocacy concerns where that was concerned, and persons advocated for communities of color, and we collaborated with the boards of health, the DeKalb County Board of Health and the Fulton County Board of Health, to reserve slots for communities of color. And so we were able to ensure that persons belonging to our community, the African-American community, were receiving equal access to vaccinations here in Atlanta. And based on the information that I most recently received, Fulton County has vaccinated about 5,000 persons, and I do believe about 70% of those persons, if I'm not mistaken, were African-American. So the efforts were clearly successful here. So that really was what the situation looked like. There was a clear disparity in the beginning. The only persons of color who were being included, as I said, were those who were of a more affluent socioeconomic experience. And so, it basically highlighted the difficulty when it came to access to information, access to services that we face as African Americans, especially those who are socioeconomically challenged. And so it was an interesting experience, and it most certainly highlighted a lot of the work that we need to do, not only when it came to monkeypox, but of course, getting to the persons here in Georgia. We have 20,000 persons, who are lost to care. We have several persons who are unaware of their serostatus, and this was really a huge opportunity to reach those people. So it did provide us with that opportunity.
Hi, I'll go next. This is Dr. Vandana Shrikanth. I'm an infectious disease specialist working at Legacy Community Health, which is an FQHC in Houston, Texas. So our clinic offers HIV care to almost 6,000 patients. So I would just want to go through some of the clinical considerations and challenges we faced with in regards to monkeypox at our clinic. And thank you, Dr. Folks and Dr. Ford. I echo so many of your concerns and observations in regards to your patient population and monkeypox. Next slide, please. So our biggest challenge, I would say, is number one was education. So the first thing we did was to disseminate information to all providers and support staff at the outset. This happened even probably sometime in June itself. And then we identified partners within our organization, the clinical teams, the operational teams, nursing, pharmacy, marketing, IT, and public relations. And then we also identified a community partner, which was a local health department, the Houston Health Department. They've done a wonderful job, and we're so grateful for the help in us treating this outbreak like it should be, with a lot of urgency. We had bi-weekly meetings with our team members and weekly monkeypox updates to all providers across our organizations. We have about 16 to 17 clinics, independent clinics, all across Houston. After hours, we also had after hours educational session for providers who were unable to catch up on our weekly updates. And we discussed all things regarding monkeypox, and we also had almost a 30-minute Q&A sessions. We also participated in local, state, and federal webinars to improve messaging to our patients, testing, vaccines, and treatments. We participated in FQHC coordination called the Houston Health Department Monkeypox Forum for Health Providers and CDC updates. So our challenge, or in fact the challenges, was to keeping up with the frequent updates. It was very difficult for providers and even us. And also sharing information in a timely manner and ensuring that information was actually received by the providers. And then we also had to make sure that all these updates that we're providing was easily accessible to our providers and in the form of a procedural guideline. Next slide, please. And then the next step was testing after the education. So initially, all the testing was done at the local health department. And subsequently, private labs were authorized to do the testing. So the consideration was, again, to send out education to our providers, stating which labs were able to do the testing, and also work with the IT department to update the diagnosis and testing codes, and ensuring there was adequate testing supplies, there's adequate PPE. And there's also adequate space for testing, followed by disinfection as was recommended. And also storage and transportation of samples, right? This was our workflow, but what were the challenges that we found at the ground level? One was the initial approval for testing from local health departments. We needed the approval. So we had to present this case. A provider, after seeing the patient, while the patient was still in the room, had to spend another 15 to 20 minutes trying to get hold of somebody at the health department. And then once the private labs got the authorization, there were different testing instructions. One said, send it in a dry swab. The other one said, send it in a viral transport medium. And in all this mayhem, there were some lost samples. And then we had to change our workflows for sample collections. And this is changing the workflows were time consuming. And also disinfection of isolation rooms was time consuming. So there was also the challenge of finding enough rooms for patients to be tested. And because of the stigma attached to monkeypox virus, we couldn't do this in open space. For COVID testing, we had an open tent, or we could do a drive-through testing. We did car testing. But for monkeypox, we had to be careful that these patients actually, first of all, be comfortable in having an open air testing, or if the lesions were actually accessible for us to do a drive-through testing. Next slide, please. And then treatment. So once we got the patient tested positive for monkeypox, then we had to consider treatment, right? And this, again, we collaborated with the local health department to procure the medication. We had provided adequate education to our providers regarding dosing, the side effects, and the workflow, how to order the medication in our EMR. And we also assigned a designated provider to be the point person for contact with the health department. So again, this was, since we did not have the medication readily available in a pharmacy, it was on a case-by-case basis. We had to make sure that we sent in the adequate information that the health department needed for them to dispense this medication. And then again, there was completion of consent forms. Sometimes we were doing telemedicine, and then it was difficult for us to send these forms over to the patients and then get them signed. They did not have access to a scanner. They did not have access to a printer. And also to keep track of all the forms that the CDC required. So this was actually the biggest barrier in providing treatment. Providers did not have time to spend so much time and effort to provide treatment to these patients. And another thing was initially the Houston Health Department mailed the medications to us, but later on, they sent it to the city pharmacy, and our pharmacists had to go in personally to pick up the medication. So these were all huge barriers for providers to prescribe the medication. So sometimes, even if the patients, as long as the patients had mild symptoms, we were like less likely to prescribe the medication. And another barrier was we also have clinics outside of Houston that was in Beaumont area, and the county there is the Jefferson County. And in that county, there was no monkeypox readily available. But luckily, the Houston Health Department did help us with our patients in other counties too. Next slide, please. And then the vaccine. This was definitely a game changer. I remember we had the Houston Health Department at first reached out to us in end of May to help vaccinate a patient of Legacy. That is how we partnered very early on in the outbreak with our city health department. So we worked with the IT to include the vaccine in our EMR, and so that it could be administered by a nurse or the medical assistant during the office visit. We initially worked with the pharmacy to circumvent the operational aspect of administering the vaccine. And when there was a change in the route of administration, we had another round of multiple meetings. One is to ensure there was proper education given out to the providers and our nurses, and also training for our support staff. So now we had changed from the intramuscular route of administration to intradermal. So we had to make sure that our staff knew how to exactly administer this vaccine and who actually qualified for an intradermal. Make sure that the children were not inadvertently being given that route. And then we also had to teach them how to upload this into our EMR and IMTRAC. So the challenge was procuring the vaccine, because initially it was there was strict criteria that needed to be met for somebody to qualify for the vaccine, and there was very limited supply. And so we could not do this on a grand scale. Like we had events for the COVID vaccine. We could not do that in this case. And then we had to send in the accountability forms, right? That was more paperwork. And then there were changes in EMR, which delayed pivoting to the latest recommendation. And that way we lost close to 25, 30 vials of vaccine while we were waiting for our EMR to show the changes. And we had to actually work on all these just to prevent errors, right? Vaccine errors is something that happens even in spite of taking all precautions. And this was different vaccine routes, different age groups, and different dosing. We had to work with a lot of that. And these were all definitely the big challenges that we at Legacy Community Health, we overcame. And now we have an excellent workflow to be able to administer our vaccines, to be able to provide treatment to our patients. Next slide, please. But the biggest challenge is to prevent burnout amongst our healthcare workers. So we have this outbreak right on the heels of the COVID. So we just did all these steps. We did all this with the COVID, and now we're doing this again with monkeypox. And I just hope we take into account the well-being of our healthcare workers and prevent burnout. We want them to stay and we want them to enjoy what they're doing. That is to helping our people. Next slide, please. Thank you. Thank you for this opportunity to share our experiences and also our challenges.
Hello, I'm Juan Michael Porter II. I'm the staff writer of The Body and The Body Pro, which are the largest publications in the world that report on HIV and AIDS. We also focus on STIs, racism, access, all of these issues. And a couple of things that have struck me based upon my own personal experience has been the way that stigma manifests. It usually comes from a place of not knowing or presumptions made about a person. For instance, when I went to get my monkeypox vaccine, I had a mosquito bite on an arm, and my nurse, who was administering the shot, pulled back from me and said, "Oh, you have symptoms." And she started to make all sorts of assumptions about me until I pointed out that this was actually a mosquito bite. And in thinking about the lack of access that has been given to providers and other medical professionals, what I think about is the medical gap and also the impulse to project bad things onto people who are seeking care. As someone who is who is living with HIV, I'm usually walking into a clinic from a place of upset or stress because I've been cut off from access. And as a Black gay man living in New York, I have seen nothing but a lack of access within my community. That's also clear from listening to our esteemed panel and colleagues here who've spoken about serving their own communities and seeing that something is not being provided to people because the decision has been made that they are not worthy. The interesting thing there is when we don't treat an outbreak, we see it spiral out of control. Currently, it's affecting predominantly men who have sex with men, and Black men are unfortunately overrepresented within that population, as are people living with HIV. But it's quite easy to forget that in 1994, the leading cause of death among people aged 25 to 44 was AIDS, because it wasn't treated. And when we don't treat these things, even as we know that monkeypox does not present the same level of death, when we don't treat things, we see them start to affect people in unknown ways because we don't know what the outcomes will be in the long term for monkeypox. And that's something that I don't see among people who I speak with, be they someone seeking care or doctors. That consideration has been lost. It's also lost with our lawmakers who funded COVID, I would say, pretty adequately, but are now declining to fund treatment or prevention access models or studies around what can be done to alleviate monkeypox. Eric LaMontagne at UNAIDS presented data at the International AIDS Conference that proved for every dollar that went into HIV prevention, the US saved $9. Across the world, in other countries, it can be up to $20. And so when it said we don't have the money to actually fund this, what's being ignored is that we actually don't have the money not to fund this, not to provide care, because the loss in life, the loss in time that goes into this, it starts to accumulate until after a while we're at a static position, and what was once a simple outbreak within a small community is now affecting everyone. Another thing that strikes me in just speaking to people across the country has been the way that misinformation has been spread, not only among media types or people who really just don't know what they're doing, but sometimes doctors themselves. When I went in for blood testing to check my numbers and whatnot, I was again faced by stigma from the person who took my draw, who saw another mosquito bite and pulled away. It's like, oh, you can't be in here. And because I am the staff writer of the body, I was able to say, this is not an active investigation, and this is not the way to treat anyone. Then things calmed down when a clinical director came in, but I pointed out that the only reason I was receiving this treatment was because of who I am. That's not the way that people who are without sustainable housing are treated. That's not the way people who present in a less, who may be in the grips of certain dependencies, they don't receive the same compassion or treatment as someone like me. And so in thinking about these things, knowing the struggles that medical providers and doctors are facing, I wonder if we can reach out to our legislators who've been elected to give us the resources so that we can survive and say, do your job, do it better. Because what is affecting that person over there right now, today, will eventually grow to affect me if we don't address it now.
Thanks so much for that, Juan Michael. Just quickly before, I'm not sure if anyone else has anything to input, but as we speak about stigma and barriers, I just wanted to highlight that there have been a lot of different incidences of stigma-related discussions happening not just in person, but also on social media. We've seen where persons are being attacked, people are being quote unquote reported to the CDC. People are getting tagged, people are getting dragged on social media, particularly on platforms such as Twitter, because they've received a monkeypox diagnosis and have decided to be vocal about the same. However, with the misinformation, which is yet another epidemic that is spreading, misinformation in and of itself, persons aren't necessarily aware of the risk that it poses, and that once someone has, gone through the motions of monkeypox, the lesions have cleared, they are no longer contagious. But we are seeing where persons are afraid to touch persons who have monkeypox. We're seeing where they're afraid to be within 6 feet of them because they are afraid. So that's definitely a huge thing that's happening here in Atlanta. I've seen it on multiple platforms where people are being attacked on social media and being bullied, essentially into, quarantining themselves from the world and confining themselves. And so we have to be very careful of that. But the other thing that also posed a huge issue for our community was the qualifications that were imposed upon providers and upon organizations that worked with persons who were at risk of contracting monkeypox. We saw where the qualifications that were posed by the CDC required you to have 2 or more sexual partners within the previous 2 weeks. And also these qualifications did not take into account persons, for example, who are adult entertainers who didn't necessarily have other resources to provide for themselves. There were no resources for persons who had a monkeypox diagnosis and were out of work for 2 to 4 weeks and had lost their jobs because they weren't able to report to work. So we see where systematically it created several different barriers, but those qualifications in particular were very difficult for our community here in Atlanta. And it had persons who were essentially lying on applications in order to get access to the monkeypox vaccine because there was this huge rush. And so being able to marshal that, you have to then look at your data and wonder, how trustworthy is this data? Because if persons have to lie to get the vaccine, or persons have to basically confess to having multiple sexual partners within the last 2 weeks, 2, 3, 5, 10, I think that's, that's very stigmatizing. It's something that, was a huge concern for persons, because having to divulge that degree of information, having to confess that to someone that they don't know, having to report that, it's not the most trauma-informed approach, especially living in a space like Atlanta, which we know that we're below the Mason-Dixon line, and we know that there's a lot of stigma around sex and sexual-related conditions. I wouldn't necessarily want to say that monkeypox is sexually transmitted yet, because even though they have isolated monkeypox DNA in semen, that we don't have enough data yet to say necessarily that it is sexually transmitted or how that's working. However, that being said, the way it was framed was such that you had to admit to being, for lack of a better term, a sexual deviant in order to gain access to the vaccines. And I think looking at that, that was an approach that needed to be revised because it provided a huge barrier to care for persons here.
Well, Dr. Phillips, I think you've given us a great segue to our final panel. And thank you to this panel and to the first panel for sharing how our advocacy can be activated and what's going on now. This panel sharing with us some very details around the clinical response. And now let's listen to the federal response. And we could have no better panelists than the 2 who are joining us in just a moment. Dr. Demetre Daskalakis is the director of the Division of HIV Prevention at the CDC. And last month, he was tapped to be the deputy coordinator for the White House response on monkeypox. And after him, we will have our good friend, Dr. Harold Phillips, who's director of the Office of National AIDS Policy at the White House. The intersection between HIV and the monkeypox crisis could not be better described than with these two good friends of AIDSWatch. Demetre, Dr. Daskalakis, please go first.
Thank you, Jesse. And if it's okay, I think that Harold wanted to go first. If that's not too disruptive of your agenda.
We're all about being disruptive. So Harold, please go first.
Harold.
Thank you, Jesse. Thank you, Demetre, and good afternoon, everyone. Really great set of panelists and terrific discussion. I just want to say a couple of things. My role, I am the director for the White House Office of National AIDS Policy. And because of the intersection of these issues, as many of the panelists talked about, I've been part of the White House team that has had the privilege of working with Demetre and with Bob Fenton on coordinating part of the monkeypox response. So I'm one of many that are in the team. But I think as the panelists have talked, a couple of things I just want to highlight before I turn it over to Demetre for his presentation. And one is that, as we talked about, especially in the beginning of this webinar, global health and infectious diseases are underfunded. And not only are they underfunded, but they're also subject to structural and systemic racism. For many years, monkeypox has ravaged parts of Africa. And so as we talk about sort of research and treatment being behind, we need to also remember that this has been something that has been impacting the continent for a while. And much like our experience through COVID-19 and now MPV, we have to acknowledge that an infectious disease anywhere in the world needs to be a concern of all of us, and that we need to pay attention and that we need to put the resources in it to understand it and to combat it. It was also mentioned the additional supplemental request by the administration that is before Congress, and I hope that you all use your position within AIDSWatch to really have some conversations to help Congress understand the importance of that supplemental request and the need to ensure that we are able to put financial resources that will help us address this on the front lines in the spaces and places where we know it's needed most. And that is our STI clinics, the community health centers, the Ryan White clinics, and our public health departments. We also, many of the things that were mentioned by the panelists about some of the challenges in this are also so similar to what we face in combating the HIV epidemic. The stigma, the discrimination, the healthcare training and understanding, culturally competent approaches. So it is all both frustrating on one hand, but also, I think, hopeful if we get the resources to be able to put the services in the places and spaces where we know that our community operates. From the earliest responses from the White House, there were those who were clear about the need and the awareness to engage and work with the community on this issue, but they also faced the tremendous task of having to move and implement systems and coordinate systems across the way while trying to do this all at the same time. And as was mentioned by some of the panelists, doing this at a time when our system was already stressed with not only sort of trying to deal with COVID-19, but the raging STI, the opioid epidemic in the United States, and now having to sort of face monkeypox at the same time. I am thrilled that with both Demetre and Robert Fenton, who understand sort of emergency response and how to move systems, and then Demetre coming in, both of them together in their roles as coordinators at the White House for the monkeypox response. One of the things I've been thrilled about is they understood the assignment. And I saw right away that they were very clear about the need for information and education around this disease, both trying to work to increase access and the availability, both changing systems and understanding the need for equity. And Demetre bringing both his experience and understanding of not only queer lives, but also the diversity of queer life in America, and trying to also ensure that their vaccines were getting as close to the community as possible, and that we began to untangle some of the issues of access. I think also in his role previously, both in New York and also at CDC especially, he understood the need to be hands-on with some of our state and local partners in this, as well as the needs of the healthcare workforce, and has been able to use some of that experience and expertise to also make some very notable changes so that the response that we have today is very different from how we started out in May. I would say also that my office continues to work with them to both coordinate and ensure that there is a syndemic approach. I was thrilled to hear about what was happening in Atlanta, where you were using part of the monkeypox response to bring individuals who have been out of HIV care into care, especially given what we've seen in some of the recent data about the link between HIV infection and monkeypox. I think it's going to be very important that we continue that kind of work. And I'm also thrilled about the letter from CDC that I think Demetre is going to talk about, that also will expand our ability to have more of a syndemic approach. So with that, I think I'm going to turn it over to Demetre. And hopefully I haven't spoken.
Harold, I'm going to go home. They don't need me. You covered it all. It's great. So good to see you. And I'll start by also saying it is, I get to work with Harold a lot, and it's been really exciting to get to work with Harold nearly in the same space. So really excited to really show, I think, one of the important things about this response, which is that people who lead in HIV have been really important in really molding the direction that this goes. And so I want to make sure that I also thank Harold for really being a pivotal part of how we've really molded the response. And before there was a coordinating office with Bob Fenton, who is a fabulous emergency manager, and with me coming in with the experience of community as well as sort of the medical piece in HIV. I think really thank you for your leadership and for your important voice and powers within the White House to make sure that things were going in a direction that were good. So I think what I want to do is give a quick update about where we are with monkeypox, and then dive a little bit deeper, next slide please, into some of the updates. And I'll say again, I think Harold already said this, but really I've been excited to be on the entire time, getting to hear sort of voices that range from policy all the way to provider. I think that one of the most exciting things, and this is more of a statement of self, about being in the White House is just the depth and breadth of communication that you can have across all sorts of different folks who have skin in the game around this infection. And so really this adds so much. And I hope that one of the important things that you hear is that we don't just listen, we act. A lot of what you said that has been said before has actually resulted in changes in how the response moves. I think Harold already spoke a bit about that, but what I want to do is just go through a quick situation update about where we are with monkeypox, a little bit about the current epidemiology, and then some updates about the response. Next slide, please. And one more. So these are data updated as of September 14th. So just to make it clear, the map on the left is the US. The darker the blue, the higher the number of cases in that jurisdiction. 22,774 total United States cases of monkeypox, which goes along with 59,606 cases internationally. Next slide, please. This is a different view of the monkeypox outbreak. This is an epi curve. Some of you may have seen these before, but just to orient you, there's a bar for each day of the outbreak. And so it tells you the number of cases that were reported to CDC on that day. The dotted line is a moving average. It smooths out the curve so you can see the trend better than all the lumps and bumps that happen, because shockingly, even if people have symptoms, they don't go to the doctor as often on the weekend to get a test, which is why you see those big giant dips. So when you see, what you can see is that from the beginning of August, mid-August to now, we've actually decreased cases by about 50%. So the curve is something that gives us cautious optimism. We are not out of the woods, and I'm going to show you why in a moment. But definitely, again, the strategy of behavior change, which is all about the work the community has done and the messaging, vaccine, testing, all of society approach to addressing monkeypox is appearing to pay some dividends. Next slide, please. So this is why I said we're not out of the woods yet. So this is a graph from a CDC technical report. It shows week over week growth rate, and it looks at different jurisdictions. So you'll see there's some jurisdictions, Georgia, Texas, New York, California, that have a nice downslope. There are others, however, that continuously have an upslope. It means that progress is inconsistent across the country, and though some jurisdictions are seeing a significant decline, there are others where we're still seeing activity and increases. So it becomes really critical that we continue the work. And I think you've already heard about the supplemental request. That work needs to continue so that we can really maintain control of this monkeypox response when we get it to the place it needs to be. Next slide, please. So I want to take a little deeper dive into the current epidemiology. All of the esteemed speakers here spoke to this, but I just want to show you some of the primary data. Next slide. So this is a graph that shows a proportion of cases that are reporting sex between men. Again, the gender is, the blue is men with recent sexual activity reported. The yellow is men with no recent sexual activity, and then you can see women and another gender identity. So I'll say this should be interpreted with caution because the last 2 or 3 bars represent delays in reporting. So realistically speaking, most of the transmission that's occurring continues to be related to sexual activity, and the majority of that sexual activity is between men. Next slide, please. And this also shows a view of race ethnicity. I always tell people to squint to see this because it's the easier way to see it. So don't sort of be obsessed with the individual colors of the bar, but focus in your mind a bit on the purple and green bars. And what you can see if you move with your eyes left to right is that the green and purple bars are growing, which means that the outbreak is concentrating more in the populations that are Black and Latino. And so it really, again, is showing us that we are seeing a disproportionate impact of monkeypox on populations, specifically those of color. Next slide, please. And this is another view that looks at sexual orientation and gender. And again, the message is very similar. The majority of individuals who are diagnosed with monkeypox identify themselves as gay or bisexual, so men who have sex with men. That's the orange and the blue part of the bars. Next slide, please. This is a really important graph, and I think it is a different way of looking at monkeypox, and it really focuses on the rate of monkeypox among our estimates of the population who are at risk. So we took data from the Division of HIV Prevention, my homeland, and looked at men living with HIV, specifically men who have sex with men living with HIV, and men who have sex with men who could potentially benefit from pre-exposure prophylaxis. When we put that together, that is a rough estimate of folks who are at potentially the highest risk for monkeypox. So that's the denominator. And the numerator are cases by state. The darker the color, the darker the red of the state, the higher the rate is among individuals who are potentially folks at risk based on this current outbreak. And so you can get a view of where really the transmission is happening and where the disease is really focused. Next slide, please. So I want to give some updates about the work that we're doing with the response. Before I go into the slides, I just want to say one of the really important things that we need to talk about is vaccine supply. And so we're going to be soon putting up an infographic that is very clear about where we are with vaccine supply with a lot of details. So look out for that. It's not ready for prime time yet, but it's coming soon. And so what's really important is that we have really worked to increase vaccine supply across every domain. So from the production side, we've worked with Bavarian Nordic, which is the company that produces the vaccine, to increase supply coming into the United States. We're going to be seeing another 150,000 vials coming into the US toward the end of September, early October, and then more vials literally orders of magnitude greater coming in soon after. We have also contracted with a different company in the United States who is going to do something called fill and finish, which means taking the raw product of vaccine and putting it in a bottle so we can use it. So that's going to happen in the US, which is going to mean that it's going to happen faster and there'll be a bit more control. Additionally, by increasing vaccine supply, by shifting to the intradermal dose, we've increased vaccination capacity by about 4-fold. So it's about 4 doses per vial, 5 maximum, but in most people's hands, about 4. So all of that comes together to say that we are really addressing the supply demand of vaccine, and now we really are entering into the harder phase where we have to work on demand. Next slide, please. So this is a view of vaccine administration in the US and illustrates my point. 39 jurisdictions so far are reporting their vaccine administration data. That means that we know what vaccines have actually gone into arms. 540,150 doses have gone into arms in 39 jurisdictions as of the September 13th closing date of these data. The graph shows the trends by date, and the lighter blue is second doses and the darker blue is first doses. So what you can see is we've done the easy work already. The early adopters have come in. They've gotten their vaccine, and I think we've heard from a lot of folks about what early providers are like in terms of their knowledge and access. So you can see that we are seeing decreases in first doses administered. Additionally, the good news is that we're seeing increases in second doses, which is really important since the Jynneos vaccine is a 2-dose vaccine with maximum protection occurring about 2 weeks out from the final dose. So we have a task ahead of us, which is we need to get deeper into the community, make sure that we're transparent about the vaccine and increase demand, but also flip the tail of having people, instead of having people seek out vaccine, have vaccine closer to people. Next slide, please. When you look at the administered doses in the 39 jurisdictions, there is a very important trend. I think we've heard about it already. I think we also heard about a jurisdiction, Fulton County specifically, that reversed this trend with some really good work. You can see that the majority of vaccines have gone into white arms. Hispanic individuals and Black individuals who are overrepresented in the outbreak are underrepresented in vaccine administration. So equity has been a cornerstone of this response. I'll tell you that my very first meeting with the president, the very first thing he said to me is, we've got to work to make sure that the LGBTQ community knows that we are concerned about their health, and we have to make sure that Black and brown people are not are receiving the vaccine care that they need. We need to focus on equity. So that was my charge. And so a lot of the work that's happened here really has focused on enhancing the equitable response to this outbreak. Next slide, please. This is a map of vaccine administration in the US. I will tell you that when you see gray, that means we don't have the data for the jurisdiction yet. The darker blues mean more vaccine administration, the lighter blues mean less. So you can see what it looks like across the country. A lot of the places that are experiencing the declines in their rate of growth of monkeypox are also places that have administered more vaccines, but also have had more cases. So it's a combination, the decline is a combination of behavior change motivated by the community, vaccine, as well as natural infections, which do confer immunity for some period of time. So this is what the lay of the land looks like from the perspective of vaccine administration. Next slide, please. And I just want to highlight the important data about what happens when community activates itself. CDC put out some very clear guidance as early as late May that really told people what harm reduction strategies could be taken. That has been translated, amplified by community, and has really become a call to action. So gay, bisexual, other men who have sex with men that were surveyed showed a nearly 50% reduction in their 50% of them reduced their number of sex partners, 50% reduced one-time sexual encounters, and 50% reduced use of dating apps and going to sex venues, so places that we know the monkeypox transmission could potentially be easier. A paper just came out today that's not from CDC that actually shows the same thing. A really significant number of folks were surveyed. I think they had about 4,000 people in the survey. Don't quote me because it just came out. But it looks as if in that data as well, major behavior change was undertaken by the community to prevent monkeypox. So it really is a testament to the community as well as the importance of clear messaging that is responsive to culture. Next slide, please. And I think we already heard about the MMWR that showed the overlap between monkeypox, HIVs, and STI. 38% of people in a match that was conducted in 8 jurisdictions in the United States demonstrated that they were co-infected with HIV when they were diagnosed with monkeypox, meaning they had an HIV diagnosis. 41% had an STI diagnosed in the past year. 61% had either HIV or an STI. So this is a syndemic, and we need to treat it that way. That's the message of the data. Next slide, please. And so that's what we're doing in the response. This letter came from CDC September 7th, 2 days before the release of the MMWR, and it is, I think, pretty groundbreaking. It specifically says that HIV and STD resources from the funding that is provided by CDC may be used to address monkeypox. It doesn't mean money that's left over. It means the money that we have now and the staff and resources can be repositioned to address the monkeypox outbreak. And that's because monkeypox work is in fact HIV prevention and vice versa. The list of notices of funding that are the funding opportunities that this qualifies for, is the Health Department flagship, it's the CBO flagship NOFO, the sexually transmitted disease flagship for jurisdictions, as well as our directly funded community-based organization. So this signals something very important, that when you think about monkeypox work, it is in fact ingrained in our HIV STD work. We're hearing some really great examples, and I'll give you a couple of what people are doing. Folks are moving their monkeypox vaccinators onto these grants and are training them to do HIV testing, pre-exposure prophylaxis navigation, as well as navigation to care. We're also hearing about jurisdictions that are looking at their out of care list and will be using the out of care list to reach out to individuals to bring them to monkeypox vaccination and an opportunity to re-engage them into care. Pandemics are important, and this is, I think, one of the clearest signals that we have, at least in public health that I've witnessed, of how important they are and how they can be critical in our response to this emergency and the pandemics that we face every day. Next slide, please. I also want to lift up the TPOXX MMWR that came out that really focuses on the first 549 people that were treated with TPOXX. The message from this one is it's safe, but we don't know about effectiveness. It's also important to note that today the CDC released new guidance that really cautioned people to make sure that they provided TPOXX to individuals who have more severe disease. There's a real concern for the possibility of resistance, which is why really focusing the medication on people with the highest risk for bad complications is most important. If we treat too many people who have lower risk for disease and we generate resistance and the virus transmits to someone and then they have a severe infection and we lose TPOXX, we may be losing the only weapon that we have in our armamentarium to treat monkeypox. It only takes one mutation to get resistance to TPOXX. So this guidance is really important. But it is also important, next slide please, that simultaneously forgot about this slide. This is also data that is included in the MMWR that shows the demographics of folks who are getting TPOXX. Again, there is a disparity. 25% of people receiving TPOXX are Black. Remember, they make up the majority of individuals being diagnosed. So again, work focused on reach to that community is critical. Next slide, please. And again, this just sort of highlights the resistance issue with TPOXX that I just spoke about. Next slide, please. What I really wanted to get to was that we also just started the clinical trials for TPOXX. There are 2 of them. There's a domestic TPOXX trial that's called the STOP trial that is just starting to recruit. And there is also an international study. I'll also say that just on September 8th, a vaccine study was also launched by the NIH that looks at various doses and strategies for administering the vaccine. Next slide, please. And I wanted to talk a little bit about our equity interventions. I like to categorize them as macro and micro, so I'll talk about the macro ones first. And so the macro ones really focus on providing special vaccine allocations to large events. The large events are pretty large, so 50,000 plus people. The strategy here is that the event has to draw LGBTQAI plus people, and specifically people, Black and Latino people who are overrepresented in the outbreak and underrepresented in vaccine. These are a couple of examples. Labor Day weekend in Atlanta was Black Pride. We provided them a 5,500 dose vaccine allocation. Over 4,200 doses were provided. 50% of the doses went to Black individuals. Over 70%, actually just under 70% of the doses were in people of color. So really a successful event. Southern Decadence in New Orleans similarly did about 3,000 doses. We're still waiting to get more information on their demographics. Next slide. We were in Oakland for Oakland Pride. We were in Boise for Boise Pride. Oakland did just under 300. No, sorry, Oakland did 1,000. Boise did just under 300. And we're coming to Folsom and Castro Street Fairs in San Francisco. And they're going to get about a 10,000 vaccine allocation. So really exciting. And these are the big event strategies. Next slide, please. The micro strategies just launched today. There is a website that we can make available to you. I don't have chat, so I can't put it in there. So we may have to make sure that we circulate it. But it is really sort of rounding out the strategy. So you have these big events, and then this is about smaller interventions. It could be an event, it could not. In fact, we specifically, I think someone talked about the house and ballroom community. In the guidance, we actually give the example of partnering with house and ballroom communities specifically to do some of these smaller events. So that's actually on the CDC website in guidance, so really exciting. So this is really designed for jurisdictions to work with community-based organizations and other communities in their jurisdiction to identify interventions to reach even deeper in the community. Having come from local public health is local, and it's even better if it's hyper-local. And so this is our strategy for encouraging hyper-local work. We're going to get some best practices, and I'm going to be excited that we're going to be able to share those as well. Next slide, please. And this is actually the web page itself. We can send you the link. Next slide. And that's the end. Thank you so much.
Thank you, Harold and Demetre. We do have time for some questions, and thank you for all those who have put questions in the chat. We said that we would collapse all three panels into one Q&A session, and for these last few minutes, we want to make sure we honor those who actually put their questions into the chat. And I think that one question very much responds to what we heard, particularly in the second panel from those who are experiencing monkeypox on the ground, and that is about the stigma of monkeypox. So I'm going to ask the first panel and the third panel particularly to respond with regard to our advocacy and what the federal responses. How are we really addressing the stigma issue with regard to particularly people living with HIV and Black, gay, and gay men of color particularly? Are there resources that we should be using? Are there strategies that we haven't thought of? Are there approaches that this group, that those attending AIDSWatch can help create in our communities to address the stigma? And are there aspects of the prioritization that we particularly heard in the second panel with regard to who should get the vaccine, and in some instances, even restrictions about who should get the vaccine that are in some ways reinforcing the stigmas that we've heard about today. Let's ask that first panel. Rachel, you and your team on that panel, any response from the community, and then Harold and Demetre from you. If you can unmute them for us, that'd be great. Well, while we're waiting, why don't we go straight to Harold and Demetre? Your mics should still be open.
I could start, and or Harold, either way. Do you want to go first, or do you want me to go first? Okay, great. So thanks again. So I think really one of the most important parts from the federal perspective, I think for this is that government needs to be the leader in focusing on ways to sort of work in an anti-stigma space. I think it really then becomes like the behavior modeled to be able to really move forward. I think that, thinking about the evolution of this response, really from the very beginning, a lot of folks were brought into the response at CDC that really had experience working with community. And then engagement with the community happened quickly thereafter to make sure that the response was really moving in a direction that was influenced by that. Those are lessons hard learned by many infections. I think COVID is one of them, but I think that the one that's nearest and dearest to my heart, and probably Harold, is HIV. And so I think that that's been really critical. I want to acknowledge one of the hardest parts about this is that the way that you get vaccinated is that you have to sort of in some places say, I am a gay man or bisexual man or MSM or whatever you want to say, and I have sex. We've seen such amazing strategies in jurisdictions. I won't call out which one, but there's one jurisdiction that when they had that sort of sign up, about 21% of the people that they were seeing were Black. The second they dropped the sign up and they made it walk-in, it was 47%, completely shifting the story. Those lessons are informative, and our close connection to the front line to hear what works really inspires our direction in terms of what we're doing in the future. So these equity interventions are that example. Like, this is how you can put vaccines places that are a little bit atypical. Also, I think, as the vaccine strategy evolves, I think that in the future, and not the too far future, is likely going to be a shift away from this sort of PEP plus strategy into the more familiar PrEP strategy. For those of you who follow HIV PrEP, I think it's really important that if you ask for PrEP, you get it. So I think that that's going to be, an important lesson from HIV that's going to permeate how we're doing the vaccine work as well. So I think it really is about really addressing the fact that that the stigma, the system unfortunately generates stigma. So identifying ways to intentionally dismantle that stigma through programming, through support, and through messaging is, I think, the core federal strategy. I'll see if Harold wants to add anything. I think you're double.
How's that? Okay. So one of the things that I would add is that I've been really pushing that we make vaccine accessible and available within the Black community. And I think that, like you said, the CDC sort of developing the messaging, but I've also been encouraging community groups to take that messaging and make it culturally relevant and appropriate for our community. And at the same time, I've been sort of cautioning people who talk about vaccine hesitancy, because as we saw during COVID-19, the gay and lesbian and bisexual community were one of the biggest community groups that had vaccine acceptance. And I think that any of us who have seen or experienced someone who has been through monkeypox, we are lining up to get the vaccine when it's available and accessible. So I've been telling people, when it comes to vaccine hesitancy, when we put the information out there the right way to our community, and when we make it accessible and available, people will do what they need to do in order to protect themselves.
Thank you for that. And I know that we are right at the hour that we allocated for this special edition of AIDSWatch, but we do have two last questions, and I think we can get response fairly quickly. Anyone from NCSD or from our first panel on how people can join the monkeypox coalition that NCSD mentioned earlier? Rachel, is there any way that you might be able to respond? And then from our second panel, doctors, our esteemed panel of particularly clinicians, are there any adverse effects or adverse responses that people are having to the monkeypox vaccine that we haven't heard about? So any guidance on how people can join that coalition? While we're waiting, Dr. Ford, Dr. Folks, Dr. Shankara, any thoughts on impact? Yes.
On impact of the vaccines and side effects?
Yes. Any adverse effects?
Well, I can comment. I can only comment on what we've seen in Atlanta, and with working with the community, I haven't heard of any side effects that have that are new or that have not been presented to the public in the general documentation. I think persons only have a slight issue with the fact that there's that little bump on the arm that lasts about 2 weeks. And we know that it can have varying degrees of itching or discomfort. Not necessarily frank pain, but I'm not necessarily seeing where persons are presenting with a plethora of symptoms simultaneously that are related to the vaccine. Maybe occasionally I might get a report of a mild fever, but that's about it. Like, that's what we are seeing here.
Yeah, in DC, we had one case in our clinic that developed cellulitis as a result of the vaccine, but other than that, it's been pretty localized reactions, just soreness at the site, and then also itchiness, like Dr. Folks mentioned.
Vandana, were you going to add anything else?
Likewise, I mean, we had the same, the generalized symptoms that are mentioned in the CDC. Those are the ones that we've noticed in our patients.
Thank you. And as we close out our first panel of advocates, Sean and Bashar and NCSD, anything you would like to add and close out now that you've heard all the responses from both the clinical and the federal response? Anything you'd like to share with our AIDSWatch advocates attending today? Sean?
Yeah, I'll just iterate what I put into the chat, which is I think one of the ways to improve access to vaccination and other kinds of care for Black and Hispanic, gay and bisexual men, transgender women, is to ensure that, because most people actually get their health care in mainstream health centers, emergency rooms, urgent care. They don't go to LGBT specific health centers for the most part. A lot of people do, but not everybody. And so I think just ensuring that those mainstream healthcare providers have training in how to provide culturally responsive and affirming care to gay and bisexual men who are African American and Latino is really critical.
Great. Yeah. All right, one last word, Bashar. I know you said you were sending out an action alert. Is that correct?
That's correct. And we can actually put the action alert back in the chat just so folks have it. But the action alert requests that Congress appropriate $4.5 billion for vaccine distribution, for testing as well. But also to that last point, it's also requesting that Congress allocate funding for culturally competent services for community health centers and FQHCs. So, and I think we're gonna, yep, it's in the chat now, the monkeypox alert. So definitely want for folks to share it and disseminate it with your networks, because we definitely need a robust response to address this monkeypox epidemic.
Thank you. Thank you. Well, we've reached the end of our time. My co-moderator, Chauncey, a final word from you as we close out?
I just want to thank everyone for their gracious and honest feedback. I think it has been really productive and really helpful, really timely and really critical. Thank you so much for the work that you do and for sharing it so graciously here with us today.
Thank you. Well, on behalf of AIDS United and our planning partners, thank you all the panelists today for being so so clear, so forthright, and so open to questions and responses. And thank you to all who attended this special edition of AIDSWatch as we address the intersecting crisis of the monkeypox crisis with the HIV epidemic. This is about our lives. This is about our friends. This is about our people. And this is the time for us to act, to save our lives, to save our health, and also to save our democracy. Thank you all. AIDSWatch, special edition, monkeypox, over and out. Thank you all, and have a good night.